Hi there, I'm Dr. Brian Litworth from Nine Wells Hospital, Dundee, and I'm active in both the severe asthma service. I'm first and foremost a pulmonologist, but also run the medical rhinology service with my ENT surgical colleagues. The learning objectives here you can see are just to give you an idea what chronic rhinosinusitis with nasal polyps is all about, so you can understand it, and we'll abbreviate that to CRSwNP because it's easier, to appreciate the role of type 2 or T2 inflammation in this condition, to appreciate which patients with CRSwNP should be considered for biologics, and to know which patients with CRSwNP will benefit from biologics, and to know their relative efficacy from the pivotal phase 3 trials and how that fits in terms of patients with upper and lower airways disease. In other words, unified airways disease, those patients with comorbidity with asthma. So without further ado, because there's a lot to unpack here, nasal polyps, when we think about those, you need to think about the underlying mucosal disease in the sinus cavities. What we mean by that is chronic rhinosinusitis, or CRS. So you can have CRS either with nasal polyps, CRSwNP, which is predominantly what I'm going to talk about today, or you can have CRS without nasal polyps, or CRSwNP. We grade these at endoscopy, which is what I do in my clinic every Tuesday afternoon, with a rigid nasal endoscope, usually without local, graded 0 to 4, depending on the extent on each side. And that means a total endoscopic nasal polyp score from 0 to 8. Normally, we would say a score of 5 or above is indicative of severe disease in terms of endoscopy. We also do a CT scan to assess the underlying degree of sinus disease, and that's done with a standardized Lund-Mackay score on both sides in terms of extent of the disease from 0 to 24. So think of the underlying Lund-Mackay score in the sinuses and the endoscopic nasal polyp score as telling you about the overall CRSwNP burden. So here, as I said, we're talking mostly about CRSwNP on the right, rather than without polyps, SNP on the left. But the two diseases are part of one continuum. And in most patients, CRS-SNP is usually a precursor of WNP. But you can see there on the right, the main sinuses are those two in the frontal bone, the frontal sinus, two in the cheekbone, the maxillary antrum, two between the eye in the ethmoid bone, the ethmoid sinus, and then two behind the eye, the sphenoid sinus. The main symptoms, the cardinal symptoms, are nasal blockage, loss of smell and taste, along with anterior rhinorrhea, postnasal drip, and associated facial pain and pressure due to a vacuum effect, particularly, for example, when stooping or when flying on an aeroplane, which can be particularly excruciating in that respect. I can tell you that from personal experience because I have skin in the game here. So think about nasal polyps as the tip of the chronic rhinosinusitis iceberg. In other words, it's what we can see above the waterline with the endoscope, and what you can't see below the waterline is what we detect on the CT scan, or sometimes you might want to do an MRI scan, but usually CT is the most favoured form of imaging. And so it's that combination of the visible endoscopic nasal polyps above the waterline and the mucosal thickening in the sinuses on the CT below the waterline, which tells you about the overall CRSwNP burden. We've already gone through the symptoms, but just to reiterate, as I've shown you in red, the cardinal symptoms when you should think of CRSwNP in your patients with asthma is whether there's a loss of smell, which is persistent, not intermittent, when it might be due to a virus like COVID or rhinovirus. Any virus can pick off the olfactory nerve. Loss of taste, anterior discharge, often yellow or green, postnasal drip with cough and sputum, bilateral nasal blockage, facial pain and pressure in the distribution of the anatomical sinuses, and patients get recurrent flares, often associated with a viral respiratory tract infection. These are just some endoscopies, actually ones that I published in Thorax many years ago, but they still hold good. And there you can see the polyps with the blood vessels on them, and the middle turbinate there. So that polyp is in the middle meatus. UP is the uncinate process, which guards the entrance to the anterior ethmoid bulla, and that other polyp is sitting in the sphenoethmoidal recess coming from the sphenoid sinus. And you soon get used to the appearance. Anyone who can do bronchoscopy, it's very easy to do a rigid nasal endoscopy, and I teach all my fellows to do that, and they pick it up very quickly. CT scan on the left, normal. You can see the orbit, the ethmoid sinuses in between the eyes, the middle turbinate below that, and the larger inferior turbinate sitting below the middle turbinate, and the septum in the middle. And then depending on where you scan, this is a coronal section, you can also see the maxillary antrum, and if you scan fore and aft, you can also see the sphenoid sinus as well. We also look at axial views as well, but they're little more difficult to interpret. And then on the right, another patient with involvement of all the sinuses, pansinus sinusitis with nasal polyps. You can see between the eyes, the ethmoids are pretty full now. There's no black stuff. There's no air. A bit more air in the maxillary antrum with polypoid thickening of the mucosa. So that would be an example of a patient, and I guess that patient would have a Lundberg chi-score of somewhere between probably 16 and 20 out of 24. Medical treatment, which we do in the clinic, we use something called the Dundee polyp clear regimen, which is medical polypectomy, 2 weeks of oral prednisolone. We use a 25 milligram tablet once a day because it's convenient. Plus or minus a once daily antibiotic, because no one takes antibiotics more than once daily. When do we use antibiotic? Well, if the drainage into the middle meatus and the sphenoethmoidal sinus is blocked, what we call osteometal complex obstruction, then there's pretty much guaranteed to be infection. And so in that case, we like to give the steroids with antibiotic cover, because obviously it's going to produce local immunosuppression. The ones we tend to use would either be azithromycin once a day for 3 days, doxycycline once a day for 5 to 7 days, and sometimes levofloxacin against once daily for 5 to 7 days. The reason we use those is, firstly, they're once daily. Secondly, they've got very good sinus mucosal penetration. And thirdly, because of the cover they give in the particular bacteria in terms of gram-positives and also some gram-negatives. Obviously, you've got to think of interactions, especially with macrolides for azithromycin, whether patients are on SSRIs. And I always try and remember to ask patients, if they're going on oral prednisolone for 2 weeks, whether they may have cold sores, herpes simplex, or a recent flare-up of zoster, because if you put patients on oral steroids, obviously it can lead to a recrudescence of herpes simplex, and whether they've got things like peptic ulcer disease or esophageal reflux, in which case, if they're not already on a PPI, stick them on one for the duration of the 2 weeks. That's followed by intranasal topical steroids. Sprays aren't really effective because they really only target the inferior turbinate, and if you really want to get into the osteometal complex, into the middle meatus sphenoethmoidal recess, then you need to use drops in the upside head down position, where the patient's hanging like a bat over the edge of the bed, and we show them how to do that. Fluticasone drops we used to use, now the supply is inconsistent or non-existent. In any event, we've switched our local formulary to budesonide drops. These are budesonide respules. The nebulization, we use the 0.5 milligram in 2 ml strength, half a vial in each nostril, in the head down position once or twice daily. And the head down position allows gravitational drainage into the sinus cavities. Some people use it with a douche or a lavage. You put the budesonide in it. Not something I particularly like to do. It's maybe something which is useful post-operatively to help get rid of all the crud and crust and secretions. But for routine outpatient use, we tend to just use the drops. If you've got a high total or specific IG, adding tyrosine and montelukast or fexofenadine, whichever is your favourite. If you do need to get rid of secretions, particularly post-operatively, then saline bicarbonate douche with a 20 ml syringe. And then finally, if all of that fails, biologics, where we use these for frequent relapsing disease despite either medical and or surgical polypectomy. Surgical treatment is usually the last resort for medically refractory disease, either a simple polypectomy where you don't go into the sinuses, you're not doing any bone cutting, so that would be what we call a microdebrider depulking polypectomy, which can often be done under local. I've had that myself. And in addition to that, usually what the surgeon would do would be what we call a full fat or full house functional endoscopic sinus surgery, or FES, with a polypectomy, and that's done under a general anaesthetic. And I have had that under local as well, not something I can recommend when you can audibly hear the bone crunching going on when they are doing the ethmoidectomy, sphenoidectomy, the uncinectomy, and the middle meatal antrostomy. Not something I particularly want to remember, and I sometimes get flashbacks about that. But that was me persuading the surgeon to do that so I could get back to work the same day. Not a very smart thing and one to be avoided. Biologics, well, we tend to use these if there is frequent rescue medical polypectomy requiring oral corticosteroid. We'd normally say anything more than 2 to 3 weeks of 25 milligram of pred a day is the kind of area where you would want to avoid using any more oral corticosteroid because of the oral steroid burden, like in asthma. Patients who are not controlled on high-dose intranasal corticosteroid, like the budesonide respules intranasally, would be another reason. Patients who have relapsed despite having had endoscopic sinus surgery and surgical polypectomy. Patients who are at high risk for having surgery, those with severe asthma who might need a general anaesthetic, and also for patients with other uncontrolled type 2 comorbidities, so as well as severe asthma, atopic dermatitis, and eosinophilic esophagitis. So those are the patients where we'd start to think about biologics. Which patients will benefit from a biologic? Well, those who have previously had a good response to oral corticosteroids, which is damping down type 2 inflammation with an improvement in blockage and smell within 2 weeks of treatment. They're the ones that usually respond to type 2 biologics as well, which kind of makes sense. If you think about it, it's treating the same cytokines L4, 5 and 13. Those who've got elevated type 2 biomarkers, like high eosinophils, more than 300 per microliter, FeNO, more than 25 parts per billion, or a total and specific IG, which is raised, so a total IG more than 100 kilounits per litre. Those who have already had an eosinophilic polyp noted on biopsy from either polypectomy or endoscopic sinus surgery, they're the ones that often respond. And patients who've got type 2 comorbidities, which we've already discussed, and particularly those with AERD or NERD, they do particularly well with biologics. Some of you may have seen this if you've ever heard me speak before, so I'm not going to dwell too long on it. You can read the index article, which was recently published in Allergy. I think it was in the March or April online 2025. And basically the idea behind this bucket is that the bucket fills with the epithelial alarmins, either TSLP or IL-33, the drip, drip, drip. Then you get leakage of downstream type 2 cytokines, IL-4, 5 and 13. IL-5 tells you predominantly about blood eosinophils, IL-4 predominantly about total or specific IgE, although IgE is also mediated by IL-13 release. And then IL-13, which is very specific for FeNO. So the story here, I think you know, if you pop your finger in the IL-5 hole, then that will suppress or deplete eosinophils, depending on whether you're using MePO or Benra. And then you'll get leakage of IL-4/13, which will result in persistently high IgE and FeNO. So you won't get complete control. And this applies to either the upper or the lower airway for that matter. If you put your fingers in the 4/13 hole with IL-4 receptor alpha dupilumab, then you'll suppress IgE and FeNO expression as type 2 biomarkers, but you won't have an effect on blood eosinophils, although they can transiently rise, as you know. And the reason for that is that blocking 4/13 involves the trafficking of eosinophils from the blood into the tissue. So if you block trafficking, you reduce tissue eosinophils in the upper and lower airway, probably by about 50%. So it's not as good as anti-IL-5 in that regard. But then you can get a backlog in terms of a transient rise in eosinophils, and in some patients, very rarely, hypereosinophilia. The other approach is to turn off the upstream epithelial tap. So if you turn off the T-slip tap with Tezi, you would think, well, what will happen is you won't get any leakage or escape of 4,5,13 from the bucket. And indeed, you do see reductions in, accordingly, eosinophils, Ig, and FeNO when you treat patients with Tezi, as I'm sure you know. But that won't give you a perfect control of the upper and lower airway, and the reason for that is quite simple, is although it turns off the T-slip tap, it doesn't turn off the IL-33 tap. So you're still getting some leakage from the bucket, and because IL-33 has an effect on downstream expression of 4, 5 and 13, and that's why if you're treating patients with Tezi, you may not get a complete hold on eosinophils. Gives you about 50 to 60% suppression of blood eosinophils, and you might get a reduction in FeNO, but you don't get the same reduction in FeNO and IgE that you would blocking it downstream with dupilumab. So that tells you about type 2 inflammation and the various drugs that you can block it in patients with upper and lower airways disease. The other thing to remember is that patients who've got type 2 inflammation in both the upper and the lower airway, patients with asthma and nasal polyps versus asthma alone, they actually have a higher overall type 2 inflammatory burden. Here's some of our own data you can see where patients who've got both diseases in the upper and lower airway, as you might expect, have higher levels of FeNO and higher levels of blood eosinophils compared to those with asthma alone. And those are patients who usually respond really well to biologics. The higher the type 2 burden, the better the response in the upper and the lower airway. And that's why patients with AERD do particularly well. They've really got very high type 2 biomarkers. So just to give you some idea, and this is a study we did, Kirsten Stewart, who is my ENT fellow, we followed patients after a 4-week running period where we put patients on Foster, Nexthaler, Mart so that we could follow the doses. So they were just told to take 2 to 8 puffs a day, use more when you need it, less when you don't, over the 4-week running period. And then they received dupilumab, 300 milligrams, which I don't think you have down south, but we do in Scotland. 200 milligrams will suffice. There really isn't much difference between the two doses, if I'm being honest. And then we follow them for 12 weeks. As you can see, these were patients who had both asthma and nasal polyps, so they had type 2 high eosinophils, high FeNO, unified airways disease. And we gave them a device called a smart peak flow meter, which measures not only peak expiratory flow in the lower airway, but peak nasal inspiratory flow in the upper airway. We had it adapted to do that. It's just a little handheld device with a turbine. In addition, it also measures visual analog scale for asthma and nasal symptoms. And what I want to show you here is the glide path over the 12 weeks in terms of symptoms improving even after 2 weeks of treatment with dupilumab compared to baseline. I should add, patients stayed on their usual intranasal corticosteroid, which in most cases was intranasal budesonide in the head down position, over that 12 weeks. So this was add-on therapy. So improvements in peak nasal inspiratory flow in the upper airway, improvements in peak expiratory flow in the lower airway, which plateaued, as you can see, from about week 6 to week 8. Also a commensurate improvement in upper and lower airway visual analog scale scores in terms of the hyposmia score. So improved smell, improved taste, and improved nasal blockage and improved asthma symptoms. And then finally, you can see on the far right bottom panel, the patients ended up using a lower dose of beclomethasone formoterol at the end of the 12 weeks with a reduction of about 2 puffs a day. So it does have inhaled steroid sparing effect. If you're wondering whether it has nasal steroid sparing effect, that study hasn't been done yet, but actually what happens in real life in my clinic is that as soon as patients start to see the dupilumab kick in, they often end up stopping their intranasal steroid, not on my instruction, but of their own volition, because they don't like using intranasal steroids because it's a bit of a faff. So I'm sure it does have steroid sparing effect in the upper and lower airway. It's just not been proven in a prospective study. That's what I'm trying to say here. If you're wondering about quality of life, because after all, patients don't come in to see me in the clinic and say, "Hi, Dr. Litworth, I think my peak nasal inspiratory flow has improved by 15% and my peak expiratory flow by 25%. I wish they did, but they don't. It's hard enough to get them to record it anyway, to be perfectly honest. But this is from the same study at baseline after the 4-week run-in, week 12 after dupilumab, and then we had a 12-week washout period after the last dose of Dupi. And here we're looking at quality of life in the unified airway in these patients. The Juniper AQLQ score on the left and the sinonasal outcome test, 22 item, the SNOT 22, looking at the upper airway on the right. These are the 2 quality of life tests. And you can see here from the scatter plot and the means and confidence intervals that you do get a quite dramatic improvement in quality of life in the lower airway on the left on the AQLQ and in the upper airway on the right in the SNOT 22. And the responder analysis in terms of proportion of patients exceeding the minimal clinical important difference, which is 9 for the SNOT 22 and 0.5 for the AQLQ, that over 90% of patients get a clinically meaningful response, as well as the effects being statistically significant for what it's worth. Well, how do these drugs compare the different biologics? So this is a paper that I published very recently, about 3 or 4 weeks ago, in Journal of Allergy and Clinical Immunology in Practice, where I compared all of the phase 3 studies for the different biologics. Trust me, it was a bit of a labour of love. Maybe I need to get out more, I don't know. And this looks at the phase 3 studies for the difference in nasal polyp score between the biologic and placebo as changed from baseline, shown as the mean and the 95% confidence interval. First thing to say, at the moment there are only 3 biologics which are licensed, but none of them are actually approved by NICE or the Scottish Medicine Consortium. And the 3 that are licensed but not approved are omalizumab, mepolizumab, those are the 2 that are currently approved, and of course dupilumab. Whether they will be approved moving forwards remains to be seen. First thing to say is that the way this is plotted, by definition, 95% confidence intervals which don't overlap, by definition, denote a significant difference, p less than 0.052 tailed, between the biologics. So that's an easy thing to look at and ascertain in this graph. Just look at the confidence intervals which don't overlap with one another, and then you know which ones are better. Second thing to say, as I've shown in red, the minimal clinical important difference which tells you about a clinically meaningful difference as opposed to a statistically significant difference, is 1. So anything which exceeds 1 is a clinically relevant impact. So let's start there. You can see here that the 3 biologics which reduced nasal polyp score, NPS, by more than the MCID of 1 was tezepelumab in the Waypoint trial and dupilumab in the Sinus 24 and the Sinus 52 trials over 24 and 52 weeks, respectively, as the name suggests. And these 3 biologics, as you can see, are superior to all of the anti-IL-5s. So that's depemokimab, its short-acting cousin, mepolizumab, benralizumab, and also omalizumab. So if you want to shrink polyps, it's very clear which are the best 2. So you can either reduce IL-4/5 signaling directly downstream by dupi, or you can block it upstream by switching off the TSLP tap with Tezi. So that's nasal polyps. Same format here, this time the nasal congestion score. So it's plotted the same way, mean and 95% confidence interval change. And here, once again, the MCID is 1, so anything which exceeds 1 is clinically relevant. The only one that did that was tezepelumab in the Waypoint trial. The others did not. So strictly speaking, only the Tezi response was clinically meaningful. But once again, you can see that Tezi and dupi have greater effects than the anti-IL-5s in terms of non-overlapping confidence intervals, certainly compared to either benralizumab or depemokimab. Omalizumab, can't really say much meaningful there because the confidence intervals are so wide, and that's why they overlap. So whether you look at the primary endpoints, and the primary endpoints from all of these phase 3 trials was nasal polyp score, nasal congestion score, superiority with either dupi or Tezi. The UPSIT score is the University of Pennsylvania smell identification test, so it's like a sort of an objective scratch and sniff test. And the only studies which measured that I have shown here. The minimum important difference is 8, and the 3 biologics, you've guessed it, which exceeded the MCID of 8 were, once again, Tezi, dupi, and these also were separate in terms of the 95% confidence intervals from omalizumab. Those are the only studies where it was measured. It wasn't measured in any of the anti-IL-5 studies. So if you want to get your sense of smell back, you know which drugs to use, either dupi or Tezi. And in terms of the imaging, so this is below the waterline, the Lund-Mackay score, the underlying chronic rhinosinusitis, as opposed to above the waterline, the endoscopic nasal polyp score. A very similar picture here. The 2 best drugs here in terms of melting away the mucosal thickening on CT are clearly, once again, dupilumab in Sinus 2452 and tezepelumab as well. And the ones that exceeded the MCID of 5, which is what you need to denote a clinically meaningful response, were those 2 drugs, and they were superior to either of the anti-IL-5s in terms of depemokimab and benralizumab. Those are the only 2 anti-IL-5 studies which reported the Lund-Mackay score. And then finally, in terms of time to rescue surgery or rescue oral steroids, so that's patients who were listed for endoscopic sinus surgery or were given a rescue course of prednisolone. So this now is the hazard ratio for time to surgery or systemic corticosteroid. Again, 2 biologics stand out, either dupilumab or tezepelumab, although it looks like tezepelumab was superior to dupilumab, numerically it was, but you'll have to take my word for it that the confidence intervals between the pooled Sinus 2452 for dupilumab and Sinus and Waypoint for tezepelumab were just overlapping, but clearly they're better than either benralizumab or depemokimab. So for the upper airway, it's very clear which are the 2 best biologics, and that is either dupilumab or tezepelumab. Pay your money, takes your choice. The interesting thing is when you look in both of these phase 3 studies, either Waypoint with TESI or sinus 24 with DUPI, although they were pretty much the same on upper airway, one difference did emerge, and that was that dupilumab was better in the lower airway, which is quite interesting. And they had the same baseline FEV1% predicted and the same baseline ACQ6 score. But you can see here that at endpoint there was no significant improvement with FEV1, with a net change of basically 0 with tezepelumab, whereas with dupilumab in sinus 2452, the mean change exceeded the MCID for FEV1, which is 150 mils, and the two confidence intervals weren't overlapping, albeit rather wide for TESI in waypoint. And it's the same story with ACQ score. Superior efficacy on symptoms for tezepelumab in terms of superiority with dupilumab in sinus 2452, where the change exceeded the MCID of 5. And although TESI in waypoint was significant for its improvement from baseline, you can see the mean change was less than the MCID. But whichever way you look at it, superiority on asthma, ACQ score, and FEV1 for DUPI compared to TESI. So that's somewhere where they do differ. And how do all the different biologics compare in terms of the lower airway? Well, this is an extensive comparison, the largest ever done. Again, maybe I need to get out more. This was published in Allergy earlier in the year, where I looked at all of the studies indirectly, comparing the various biologics. A red circle denotes that the first name biologic was superior to the second name biologic, and in those cases the confidence interval for the rate ratio for reducing the annual exacerbation rate was less than 1, so by definition significant. If it's black and the confidence interval cross unity, then it wasn't significant. A lot to take in here because there's a lot of studies, so I'll summarize that for you. And the bottom line is that what was shown when you sort of look at this overall is that dupilumab was superior to either MIPO, Benra, or omalizumab, and also tezepelumab was superior to benralizumab as well. If you want to know what happens in type 2 high patients with eosinophils more than 300, that's shown here in the same format. And basically, in this case, TESI, DUPI, and MIPO were superior to Benra. These are not prospective head-to-head studies because none have been done. These are indirect studies comparing the two drugs which have been published. So just to wrap up, think of CRSwNP in any asthma patient who presents to you with loss of smell and taste. Unless you ask about it, you won't find out. Very simple to do. Secondly, patients with unified airways disease who have asthma and nasal polyps, they have a higher type 2 burden, so they respond particularly well to biologics in the upper and lower airway. Thirdly, the response to oral corticosteroid in CRSwNP predicts the response to biologics, and I guess it's the same in the lower airway as well in asthma. Fourthly, patients with type 2 high CRSwNP, they respond best to biologics. In other words, those with raised type 2 biomarkers, including those with comorbid asthma who have higher type 2 biomarkers, and particularly those with AERD or NERD. The relative ordering efficacy in CRSwNP, as you've seen, is that DUPI and TESI are better than anti-IL-5s or omalizumab. The efficacy in asthma and chronic rhinosinusitis, as you saw from the analysis of waypoint and sinus 24 there for ACQ and FEV1, dupilumab is superior to tezepelumab. But on exacerbations, there's really not a lot to choose between them, to be honest. So the choice of biologics should clearly be determined by efficacy in both the upper and the lower airway. In other words, what I'm trying to say here is if you've got a patient with severe asthma who qualifies for biologics according to the NICE criteria, and they've got refractory CRSwNP, then to me it makes sense to put them on either DUPI or TESE. So thank you very much for your attention, and I hope you enjoyed the talk and enjoy the rest of the meeting. Thank you.